My name is Dr. Jessie Sherrod. I'm a pediatric infectious disease specialist and a graduate of UCLA School of Public Health. Want to commend you on such an outstanding model. My question is concerning the patients and whether you had a component to look at education of the patient in this process.
Yes. So specifically that last model I talked to about the Flint, the interprofessional care model,
Right.
and several other of our processes that we're going to improve upon. We did quality life surveys plus patient activation measures on how well the patient understood their present health condition. And then we measured the outcome after the experience with student engagement, both dentally and interprofessionally.
The other question is concerning demographics. Did you have any demographics of the populations that you were working with?
Yes. In the first couple of slides out of those 22,000, we shared in the state of Michigan what the breakdown was of ethnicities and ages, if you will. Does that answer your question?
Yeah, I was looking for ethnic groups and utilization based on the different ethnic.
We did not go into utilization per ethnic group. We just measured what ethnic group showed up for our clinics.
Right, so you're kind of demonstrating that just by making services available improves access to care.
Absolutely.
Yeah.
Spot
Excellent,
on.
excellent model.
Yeah, spot on. Thank you.
Thank you.
I thought I saw another hand. Oh, yes.
Yes, I'm Glenn Lopez. I'm a family physician and work for an FQHC here in town that has some dental clinics within their primary care clinics. It's fabulous. It's just so great to be able to work with dentists for all the oral health issues.
You're living it.
Oh, yeah. It's fabulous. I'm curious about using students. They're not dentists yet, so you need a dentist who is going to be dedicated then to supervising a number of students. And I don't know how it is in dental health, but in primary care, it's a hard sell to bring on students into a primary care environment. Just
totally different model
for the clinic, because you don't have a physician seeing the patients, and then it just slows down the process tremendously. So I wonder how that works in dental health, and how have you been able to address that? As far as the FQHC is concerned, is that seen as a potential deal breaker at some point where, is it actually, can you show you've obviously been able to show its benefit, but maybe if you could expand a little bit more on that issue.
So what we do when we go out to a site is we ask the dentist to tell us what their strengths and weaknesses are. And then we have meetings about credentialing. What are they capable to do? Because they never should do a procedure that they themselves cannot do themselves, right? Quite simple. I like simplicity. So we talk about, are you a good teaching candidate? Are you a good teacher? Should you do this? Just because we're going to an FQHC and there's going to be several dentists there, doesn't mean all of them have to be a teaching dentist, just those that want to be, okay? With that said, with only 738,000 people being treated out of potentially 13 million, those dentists of record sometimes can be booked up 3 months in advance, and if there's an urgency, we tell them, let our students do all the urgencies per day and let them follow the case, because you can get them in that day, okay? The transition then, I will tell you, on exit interviews, our students, by patient evaluation through Press Ganey and a couple other programs, the patients actually wanted to be treated by the students because they said they were more compassionate. Okay? Because they haven't been hardened. But I also don't want to deflect upon this is we were able to identify and treat the problem that day. And one thing our students are really good at is triaging medical histories. So when you have urgencies coming in, that alone will save time for the attending. Okay? So there's different models, but normally we work on the urgency factor. I once walked into an FQHC and there were 17 people on a Monday morning waiting in the waiting room with non-scheduled visits. It was an easy thing to transition because our students are being taught to be independent practitioners the day they graduate. So I'm sending out students next Monday. This is 3 months away from when they get to call me Bill. Okay, and if I'm not confident in that product, then I better go back and figure out what I have to do differently. And that's what I'm doing with those assessments. So first off, we teach the process, okay, of how to be a good teaching dentist. And then through evaluations of our students, we find out if that person is a good teacher. But overall, it's communication to the patients. And I have to tell you, we have not struggled with allowing patients to be treated by students at all, okay? Because in primary care dentistry, meaning exodontia restorative care and pain management, I have data that shows that our students are 0.7 as affected as the attending after their first rotation. When it comes to dentures and crown and bridge, that's not the case. But that frees up time for those providers that are more skillful at that to do that more dutifully and not be rushed in that environment. So it's a win-win. And again, I wouldn't have gone from 4 clinics to 39 in 2.5 years because we weren't proving the point. So if you want a demonstration model, you want to become part of the process, please look us up. I'd be more than happy to explain this. Okay, thank you. Anyone else? I don't bite. I like to eat elephants.
Hi, I'm Flory Brizzell. I'm just a member of the community. I don't have a question. This was just one of the most exciting lectures that I have heard in a very long time, and I am so excited to be part of this community and to be able to watch this happen.
Well, so far at UCLA, I thank you for that comment, but I've been all talk and I have to perform on Monday.
You do.
But I appreciate the positive note. I really do.
Hello, my name is Hannah Reichel. I'm a second-year public health student in health management and policy.
Okay.
Actually, I'm a Michigander. I grew up in Michigan, and
What city?
I went to MCDC dental clinics as a kid, so this was kind of a fun.
Oh, really?
Funny. And then, as a young careerist, I moved to Grand Rapids, and I helped in FQHC open a dental clinic.
Was it Cherry Hill?
Yes, exactly.
Yeah. One of my prize partners.
Yep, great work coming out of that place. And then when I was doing that work, it was straight out of undergrad, I encountered a lot of management folks who were really passionate about expanding the reach, really
Right.
understood the needs of the community, and knew nothing about dental.
Right.
And I, at 22, became the subject matter expert on opening dental clinic in Grand Rapids,
wow.
which I was not qualified to do. And like, no, it's not like that. But I guess my question for you is, as you bring your model to UCLA, and we have such rich resources here in terms of both management and dental clinicians, do you have plans to incorporate policy and management skills into the way that the dental school curriculum is happening, and vice versa? Do you have ways in which students from other schools that are really in the same space can participate in this model?
I welcome your input to come to our school to explore, because you're part of the interprofessional team that we hope to develop. But I have to take baby steps, and that is I first have to prove our dental component, just like I did in Michigan, that allowed me to now expand the interprofessional care model to 6 different locations. And I have to tell you, so we have to walk the walk and talk the talk first with the dental, and that as the baseline, we will add. And if there are things that you want to explore through this, I'm going to say, I'm sure you could be enlightened, or you can enlighten other people as to what's out there. But I'm actually confounded that I just shared with you a process that I could increase the number of providers by 133% by doing the right thing. Is that not a powerful statement to share? So I look forward to working with you. And thank you.
There's a, yeah, right there.
Hi, I'm Stephanie Arlo. I'm a board member of South Central Los Angeles Regional Center
Okay.
that represents various special needs populations. And I'm wondering how you're driving traffic to these clinics.
I'm not quite understanding that question.
I guess what
I'm
it
just
is.
trying to help the traffic that comes to the clinic right now.
Okay.
So are we soliciting more? What I want to say is, I will tell you that I believe that some of the FQHCs I've been working with have much more capacity than what they're doing now. And that's what we're trying to do. And by doing that, we will then drive other entities in. Now, 2 rows behind you are 2 of our finest doctors that provide care for special needs, okay? And we are actually in discussions now on how do we expand their knowledge base. So Dr. Parks and Dr. Song are 2 people that are going to be heavily involved. And this is something I'm going to tell you that why the program is now on steroids. I did not have a pediatric dentist before as a set of eyes. I did not have an oral surgeon. I did not have a special needs dentist to tell me what I should be looking at and to qualify this more dutifully. So this is going to be somewhere where I'm reaching out to our team of experts in our school to be that factor because, Dave, you remember what I told you? I don't want Dave to be a great teacher at one of my clinics for 2 days a week. I want him to train the next person that is going to be his little minion that becomes the next minion that becomes the next minion because, quite frankly, I was so happy that I went to an LA Trust meeting last week. Was it Friday, Lisa? 2 tables over was a dental student that was a graduate of my program 10 years ago and is now a dental director at South Central FQHC. Wow. That just kind of touched my heart, okay? And he said it was that experience of why he became a dental director for a FQHC. So, I'm not taking on the task of driving patients, but we become community service and let them know what we're capable of doing. Okay, and by being there, we are going to increase access to care.
Yeah, exactly. How do you let them know? I was kind of wondering that too. How do you get the patients to come?
You know what? This is going to be something that I will learn on the job because different clinics have different levels of expertise. That young lady that just asked the question from Grand Rapids, that was a machine. They had a patient base of 40,000 patients plus. Okay, 29 dentists at, 7 different clinics? Yeah, I think now. Okay, and we were present at 3 of them. I'm going to tell you what really gives me joy. They expanded because of our program in dentally, because we facilitated bodies to them. Every year, they took 8 to 9 of our young dentists coming on board, and I taught one of the new dental directors. You know Dr. Hill, Tim Hill? What a wonderful guy, okay? And he's going to take over the reins of running that company someday, and I mean, what a great role model. So these are the people that I'm saying to you is that how they market to their community, that's on an individual plateau, but we're going to help those communities because, quite frankly, we're going to have a UCLA placard on these communities now saying UCLA Oral Health System or UCLA School of Dentistry. We're going to do something to be known as being part of the community.
So have you presented this model to the medical primary care people?
No.
It's an excellent model, I think, for...
The school, it's been an easier sell with the School of Nurse Practitioning and to pharmacy. I've had good success, and to social work. So I'm saying to you is that, unfortunately, where I came from, University of Michigan was not known to be a primary care medical school. It was more about research and specialization. But I did reach out to other medical schools with Michigan State, Central Michigan, Western, and Oakland University, where we were going to start developing a model, and then Dr. Krebsbach took me away. Yes?
Hi, my name is Maria Gonzalez, and my question is, do you have any data of the percentage of students that graduate and whether or not they go and work at federally qualified health centers?
Yeah, that one slide that I showed, we had, in our best year, we had 24 out of 108 students go on to public health clinics after graduation. So ever since the last 7 years, we've averaged in the mid-teens.
And again, the national
And
average,
the national average is 2%. So that's what I'm saying is that if everyone had the outcome of that school, we would add and well then double the amount of providers.
What did you do? Was there curriculum that kind of, how did you get from that to 13%?
Well, what happens is that this was part of a course, and before they were sent out into the field, we taught them about how to navigate the third-party payer mechanism for that particular model. We taught them business management principles to be comfortable in that arena. We opened their eyes to opportunities, and I say we had the 7 models, and the 2 models that I really am looking forward to creating, well, one in particular called the Dental Service Organization. If they just did it for the right reason, and reached out to a segment of the population they normally don't treat, they'd probably be better off. And I actually have been a consultant to several of those groups. This is something where I want to explore and make those practitioners that truly do treat underserved populations, make them the best they possibly can be. I'm all about servicing the people 200% below the poverty level. I'm not here to be competition for general practitioners that have a private practice. But I want to teach them how they can be engaged. And in fact, in those champions, a lot of practitioners come back on their days off during the week and actually work in public health clinics.
Bill, is it fair to say that there's been a perception traditionally among new dentists that these jobs in federally qualified health centers are kind of second-tier jobs, and
Sure.
that, and also that our curricula on a national level do not typically expose students to actually immersion type of experience in these
Right.
centers? And so it seems that with that enormous increase in your graduates choosing this, that they're finding some value and some fulfillment.
No question. And I have to say to you is that when I graduated from dental school, which was a couple of years before you,
Couple.
if you went into public health, you were probably considered less than an adequate provider. And I will tell you that's not the norm now, because those 117 docs that I had the privilege of credentialing, I can't even lick their boots. They're that qualified. All right? This is an arena, truly, when you're seeing anywhere from 18 patients a day that are medically compromised, and you have to think like this, I have to tell you, these old bones don't work that way anymore, okay? But I can supervise a handful of students to be more productive. Yes.
You were talking about building capacity, and it sounds like you're doing a great job that way. But you also mentioned that we're treating in California less than 1 million of the 13 million that need to be treated. So what do you project is going to happen with the programs to reach the other 12 million people?
Again, FQHCs are only one of several models that are addressing the problem. And Dr. Kroll, whenever you want to interject, because that's my stats guy, I mean, he knows more about this than all of us probably put together, but I'm going to share with you is that I'm trying to take one component of it, but I'm going to say to you is that if my students choose any one of those 6, 7 models that we're displaying, we're going to get there. Because quite frankly, I need roughly 10% of all dentists nationally to come into public health arena to some capacity to get the underserved populations to the level that they need to be addressed. Yes?
Bill, I just want to add, yeah, it was the paper we wrote a little over a year ago that really, I think, even woke up the people at the federal level about the small proportion of federally qualified health centers, despite over a decade of additional funding to add dental clinics, to new clinics or clinics that wanted to expand. You're still looking at only roughly a third. So if you, I mean, we wrote a paper for the National Conference of State Legislatures 10 years ago that basically said if you looked at that as a model to really try to further two things, both the access to care and the professional education of dental care providers, much like you have under, a disproportionate share of hospitals that get funding that also have residency programs. I mean, that's the thrust that has to happen. And, where would you get all of those additional dentists today? You're going to pull them out of private practice? Not too likely. But if, you've got a stream coming forward that you could help to fill a part of that gap, it would go a long way.
So basically what I outlined on the map there is dental education. I hope to be one of the leaders in that with our dean and our school, and that is, let's create our own dental service organization, because right now the model exists in 5 states, right? And we're going to be doing it for the right reason. So why not do it for, and teach other people? Because one of the things I'm passionate about is training the trainer. I want to train other people to be able to do this with confidence. As a matter of fact, I want everybody to steal the model. This is all for the right reason, right? I don't know. also with Dr. Krall's study, we're never going to service our way out of this problem. And the programs he's working on with prevention and also incorporating medical personnel into being aware of how to prevent, this is where we're going to go, because the last stat that I looked at, it costs 35 times more to surgically remove the problem than to prevent it in the first place. So it's going to take a slow process, but right now the numbers are daunting. I mean, think about it. If about half the population is at 200% of the poverty level, and this is one opportunity in the state of California, that's 40 million, it's 20 million people, and we only fixed 798,000? I got a problem with that, okay? And it's all about creating more opportunities. Any other questions?
Right down in front. Oh, sorry, I think that was, oh, go ahead.
Just is curious, I can ask a tangential question about why it is that dental care isn't integrated into healthcare. Why isn't it all just one pocket? But that's a separate question.
That's a loaded question.
Yeah, I'm sure it is. And my question is, so, we're talking initially about people who are at the lower end of the income spectrum. What about like the next rungs up? Is not that the ACA is particular popular these days, but if there was a sort of ACA for dental health, what might that look like? Or is that also a question?
I would say this is that you have to look, just like I explained on the map, there are a lot of public health centers that wanted to build their own clinics. Do you know how much available space there is within communities that is not being utilized? So some of those projects like that one where we had the donated service program with Renee Luchart, we sublet a private practice office because I said it was ludicrous to go build a new facility. And we paid the private practice office, the health department found the money to do that, and we reimbursed the site 16% of usual and customary fees based on Delta Dental PPO, and everybody won. Because that site was getting a couple $1,000s a month for literally doing nothing, right? And we brought in a team to take care of the poorest of the poor, and everybody won. The site was rewarded both financially and philanthropically because they were perceived as being a leader in the community for offering up their site. I mean, so when you're doing the right thing, it's like a virus, it spreads. But going back is, do I need separate siloed stations, just to have dental? No. There's way too many opportunities within the present system. We just have to make sure that the capacity we have is fulfilled. Because all too often, we are not directing patients to those clinics adequately. And it is about marketing. And it is about providing a good product and changing the culture. But for me to have someone that came from an affluent family and go work in Timbuktu in northern Michigan because they like it, I will tell you this. One man's hell is another man's paradise. I love hunting and fishing, and someday I plan on being a part-time dentist in one of these off-site clinics and work 2-3 days a week with a bunch of students and go fishing every other day. That's just my life, right? But again, that may not sound appealing to you. You may want to be there because you're a surfing guy, right? And you want to be in LA. Well, you know what? Be a provider. When you retire, go work with students and do this, because that was the number one faction of growth in our program, was people coming out of retirement and feeling worthy, having purpose. Like I said, our retirees are turning into millennials. Got to have purpose in life. Yes.
Yeah, just one last word. I think the key word is exposure. You
Yeah.
are, and while they are in their developing stages.
I'm saying what absolutely drove everything was a well-run organization
Right.
and mentorship. And that mentorship can actually happen virtually. Okay? So someone here could nurse through someone out in rural America, but they're the solo practitioner if there comes a difficult time. We want to make these exposures comfortable for people that go into these areas, okay? That they actually have a reliable resource to become productive. I always tell the students that I worked for an idiot for 4 years when I graduated. You know who that idiot was? It was me. I started my own practice, and quite frankly, I did not deserve to have my own practice.
But your
Or I should
model-
not, because, as a clinician I was fine, but as a manager in a business, I was evil. And you know what? I told my wife, I'm not going to continue to be this person because I kind of like myself being happy. And then growth development came on how to do practice management and become a better person, actually.
Yeah, well, you have good organizational skills. It's an excellent model.
You think?
Well, like I said, it didn't happen without mistakes, believe me. And as I told our partners right now, there's going to be a learning curve here as well.
Bill, I think we have time for one more question, and then we're going to have to wrap up.
Yes, sir.
Here, but 20-something years ago, I spent a morning in the largest sugar mill in Central America, and they had a large primary care program, and they were very proud of their dental program as well. They had developed some sort of a U model where you had one dentist working with 3 dental assistants and somebody in the middle doing all the, I don't even know what you call it, I'm not a dentist, but all the filling materials and whatnot, and handing out the supplies to the 3 people, and this dentist running around. They were seeing about 2,000 people a month. Just one dentist and those extensions.
Utilizing auxiliaries.
Exactly. And you alluded to that at the beginning, and you sort of didn't go into it. And not that you should argue with success, but
no.
Could you comment on that?
My biggest nemesis right now is the curriculum of dental education. Can we allow our students to go into the field in the 4th year? Because there are too many classes right now that we're trying to get into the 3rd year to allow our students to do more service. And that's not going to happen overnight, okay? So we have to move the curriculum to make it more palpable. But that's why we want to do the telehealth and telementoring, because I want my students to be able to take classes if they're out in the field, that they take an hour break to listen to this lecture, okay, and then they go back to work. So we shouldn't be just confining it to a classroom. If they're out and they have to take a test or something like that, let them take the test, out in the field. So, but the other thing I want to share with you is that if we allowed space and time for every year of dental education, we could really expand access to care, because I really see 1st and 2nd year students in school-based programs, for instance, doing fluoride varnishes, assessment, and preventive mechanisms, okay? But the curriculum does not necessarily allow that, but it can. So as they become more adept with procedures, we can then have just restorative clinics. We have pain management clinics, and then refer the more complicated things back to some dental home. And that's one thing that Dr. Kroll is working on right now, is getting this registry of where do the patients go once they've been identified with a need. Once that loop. But isn't it amazing that if we have 13 million people or 3 million people going in for medical, but only 798,000 at actually dental, I guarantee you that every one of those 3 million people needs something. And why isn't it part of the regimen of triage coming in? You check your mouth, your tongue, your nose, your ear. Well, stop over here and get your teeth cleaned and assessed too while you're at it. And we're finding out there are mechanisms on how to triage that patient from 6 visits down to 3 for a baseline. We've proven that. So I'm just saying it's just a mechanism how you make yourself more productive. Because we're not all about just productivity, we're about being efficient. And that's why I look at things through that Malcolm Baldrige Award eyes. How do we streamline things? Have any of you been part of Sigma 6 or Lean 6 principles on, if you can do it in 8 things, you could probably do it in 4? This is kind of where I'm at with the whole thought. But at this time, I'd like to take a time and just ask Dean Krebsbach to stand and give some comments here, because he's had a hellacious day. And, and I just want to make sure I didn't miss something that he wants to share with the crowd, because he is the leader. Sorry, Dean Krebsbach, I need to put you on the place.
Thank you. We just had a middle of our accreditation site visit the last few days, so it's been a stressful week. So, no, I just want to say, Bill, that you hit it out of the park. It was a great presentation. We're glad you're here. We're going to do really great things. There's so much need, and we're really excited about partnering with the whole health system. Someone you asked the question, why aren't we a part of health, right? That is it's a 50-year-old question. But you can't have health without good oral health, And we want to train our students to be working in an integrated healthcare system so that we are working towards something that is a healthy people and not healthy eyes or healthy kidneys, or healthy oral cavity. So we need to be a healthy population, and this is just one part of that mechanism, and we're really excited to work through this, and thanks, Bill, and thank you all for attending and asking really, really great questions.
And I thank you for the time. Thank you. Thank you so much.
Thank you.
Thanks.
So Hannah stole my thunder, not for the first time and certainly not for the last, but I saw on your slide about interprofessional education that public health wasn't there. And in my role as Associate Dean of Practice, I want to offer up our students to participate in the interprofessional education
Awesome.
efforts that you are undertaking, and we would love to help you. And I'm hopefully some, but certainly I'm inspired by the work that you're doing, and I think that our students would really enjoy participating. So thank you both to Dr. Hewlett, Dr. Piskorowski. Thank you to you for coming. I want to let you know that because the March Health Forum, well, there won't be a March Health Forum because it conflicts with spring break. So our next Health Forum will actually be Wednesday, April 25th. So stay tuned for more announcements about the speakers and the panelists, and I hope I see you then. Thank you.